and welcome to Dil Ki Recipes. For this episode, I am super excited that I have with me the very accomplished, very distinguished Dr. Umar Latif, who's a psychiatrist. And of course, I'll say and share a lot of detail about his competence. But welcome, Dr. Latif.
Yeah, thank you so much, Sheeza. It's a privilege to be here. I'm really excited. You're a trusted colleague, and the impact of the work you're doing, we're seeing it in our community. So I think this is a good platform that you have right now. Excellent.
Thank you. Thank you so much. So I want to brag about you for a minute, Dr. Latif. You are a distinguished fellow of the American Psychiatric Association, triple board certified with about 20 years of experience. And what I love about your numerous accolades is your specialty in geriatrics, in addiction psychiatry, very, very difficult, complicated taboo topics for our community. I'm sure you'll be okay that we will be attaching. We can contact you at the Noesis Clinic. You focus on a lot of things like Alzheimer's detection and, these new, and I would love to know a little bit more, maybe in a different podcast, about your transcranial magnetic stimulation. You're also a professor at Texas A&M. And of course, you have your newsletter. And Dr. Latif, with your permission, we will also post a copy of your newsletter so people do have access. This psychiatry is something our community doesn't have that much access to, valid information that may also feel culturally appropriate, because those things do matter to our community. So I so appreciate you being here.
No, thank you. It's a privilege. So looking forward to our talk today.
Absolutely. So I want to jump right in. And today I would love for you to wear the hat of that South Asian person. And I know you have personal experience. Given you're from that descent, we have a lot of things happening in our community. There's loneliness, there is intergenerational trauma, there is a lot of achievement pressure because a lot of people are, whether it's pushing children or even feeling like we as adults are not enough in terms of how much we do. Needless to say, the level of limited information we have when it comes to mood disorders, personality disorders, and so forth, and then the big cultural stigma around mental health. So please tell me what you're noticing in terms of challenges.
I think you're hitting the nail on the head. So, from my vantage point, there's a cognitive dissonance, right? Our South Asian community, our immigrant diaspora, or even our third culture generation, right? We can have different ways of looking at this cohort, which is our cohort, right? I'm an immigrant here. My father actually, incidentally, was a psychiatrist back home in Pakistan. But this cognitive dissonance is very high achieving, outward, successful, really self-driven, self-made people who have this performative life. And the cognitive dissonance is that inside, it's not connecting, it's not landing. So that amplifies anxiety, that amplifies imposter syndrome. It amplifies this hustle culture of, yes, I was rewarded in this professional part of my life. And it doesn't just mean like doctor, engineer, and stuff. Very successful businessmen, right? So I'm really doing the hustle, doing the grind. My bank balance is good, but those skills are not translatable into the bio-psychosocial realm by which we look at mental health as being successful or not, right? If I were to distill everything, it's that gap within which people are feeling misaligned. And that's where mental stress happens.
Absolutely. And this cognitive dissonance you're talking about, I wonder what feeds this avoidance of emotional struggles. In some ways, like you're saying, we have a performative culture, but there's this avoidance of even acknowledging that somebody is struggling emotionally, that almost amplifying the successes. But people are smart. They notice that people are struggling, but there is this minimizing of the challenges. And I'm wondering, how did we get here that we're feeding into this, even in today's day and age?
I think there's some of this is just generational, right? Because I was trying to read up a little bit, with curiosity, because it's like our men are not in touch with our emotions, right? And there's this narrative of misogynist male culture. But I came across something interesting, that some of those are internalized learned behaviors, because the very women in our culture who suffer from that are the mothers who taught their sons, you're special. The daughters are secondary. We'll sell our lots to get you to wherever you need to be for higher education, but our daughters will just get them married away, right? So some of this, I think, becomes internalized, and I found it almost ironical that there's this codependency, right? So I would posit or argue that to some degree we have a heightened, misplaced sense of emotional engagement, of codependency, people pleasing, external validation. My measure is not who I am, but who I know. To live off of this network, you do need to have some social engagement skills. You can't be completely deft of EQ, but it's just skewed in a very external kind of way. It's amplified in the wrong space.
You're going to be in so much trouble, Dr. Latif, for saying what you're saying, because actually in a different podcast, we've talked about it, how the older women generation is perpetuating this misogynistic behavior because of so many dysfunctions that we have in the family system, right?
Yeah.
Their way of figuring things out, and culturally, the women were given a lot more importance when they had a son because they felt like the generation was going to move forward. And then, needless to say, because of emotionally disconnected marital relationships, there you have recruited what is called a surrogate spouse in a son. And so a therapist asked me that, it's so interesting that my South Asian clients have struggled with understanding their wife's emotions, but they're so tuned into their mother's emotions.
Yeah.
So the other one that is almost anxiety inducing is, teenagers go through FOMO. And I feel like our community goes through FOMO even in their 40s and 50s and 60s, the anxiety of not being included, being othered, not invited. The social network and overemphasis on that, I am sure, is creating its own diagnoses of psychological challenge.
It's this exponential layering of things. When we look at, there's a graph where they put over the last 2 decades emergency room visits by teenager girls in the US who would present to the emergency room for non-suicidal self-cutting behavior. And they looked at that graph, and then they overlaid on that graph the year when those teenage girls were the first cohort who grew up with social media. And it is sobering and mind-blowing to see an exponential rise. So that's just one data point. If we look over the last decade, there's been a 4 times more increase in suicide attempts in young girls and young women. And then you have a generation of a young cohort who grew up in COVID. So now, biographically, they grew up, and mentally they got stunted. And that's why in our clinical field, we have these programs of failure to thrive. Where did that word come from? Because it's almost like you've shunted a decade away normative growth pain and angst and everything else like that. But then there's another, we've actually moved into now this AI generation where there are clinical validated studies that show that the large language models of AI, they are sycophants. Being a sycophant as a human being means that you are over-pleasing, you are going to agree with everything, even when you're saying it's wrong. And so when this generation is starting to seek self-validation from a large language model, we are seeing real suicides happen. We are seeing patients becoming psychotic because it becomes an echo chamber. It is continuously deconstructing the social fabric of just a lack of resilience and grit.
It is such a painful topic, but I would like one follow-up question. As you're noticing the South Asian community, especially these teenage suicides, and the number that has just increased, and it's not just in the state of Texas, but in other states as well. I want to talk about is that intersectionality of faith, belief, and psychiatry, and the struggle, whereas in my view, there shouldn't be any, because they're beautiful in their own space and they're so valuable. So I'd love for you to talk about that, because a lot of times these teenagers that you're talking about, and when I used to do a lot of groups with these youngsters, and they would talk about how when they would report, because this is a generation who also knows that they may be depressed, that they're struggling because of social media, their awareness is so much higher, that they get these comments from parents that are so dismissive about your faith not being strong, or you pray, or,
It's shame-based. Let's put put Islam as a religion to the side. I'm going to come back to it. Let's just look at spirituality as a construct, non-denominational spirituality, right? My belief that there is something, a higher power beyond just me that gives me some sense of meaning to my life, right? Because otherwise, either a sense of ennui sets in, which becomes fashionable, or this existential crisis comes in, just the horror of Carl Sagan, we're just small blue marble, and all of that, right? So science has shown and demonstrated that biologically, medical illnesses improve better in patients who have a connection with spirituality, right? So I'm not talking about Islam, I'm not talking about other faiths, I'm just talking about, okay, let's say agnostically, you cannot diminish the impact of that. A lot of my work has been in trauma. Childhood trauma, generation trauma, combat trauma, complex PTSD, and then it morphed into work into burnout and moral injury, right, in healthcare workers. So there is a body of science that talks about moral injury as being the wound of the soul. So we can see when you ignore spirituality, it's not just bio-psychosocial, it's bio-psychosocial-spiritual. And then you cannot ignore the value of that. The challenge becomes, and here's what's ironical, right? The skills are not translatable. There is a stigma in our community. My therapist used to say, I'm not a rent-a-friend. I'm not having people just come to me just to talk to them. Therapy is a rigorous science. It is evidence-based, structured. Every word, every pause, every inflection that a therapist does or does not do has years of training behind it. But the patient doesn't know that. And in not knowing or understanding that, they confuse sympathy, which they're used to, with empathy, which is a totally different construct, right? Our religious community leaders who are very skilled and versed and knowledgeable in faith cannot translate that skill set into science-based, psychology-based by itself or vice versa. It has to be a collaboration. Here's where my skill set ends, and I'm going to pass the baton on to you, and we're going to do a community interdisciplinary kind of intervention and stuff. Because here's the irony in it. If you really look at Islam, constructs like cognitive behavior therapy, constructs like existential crisis, constructs like mindfulness, there are centuries of faith-based interventions that we have forgotten and we made them way too complex. So depression koi cheez nahi hai, namaz padho jaake. It's not either or. And
Exactly.
the other challenge is that we have to not project our wishes onto our clients. We have to meet them where they're at. Maybe they're not at a position in life where they're as connected with their faith. Please don't make them run away from it. You don't have to pull them voluntold, but give them space to be curious, to connect.
I couldn't agree more. I'll tell you, Dr. Latif, one of the things that I struggle with as a counselor, therapist, coach is finding really skilled psychiatrists who understand that each one of these things, whether it's medicine, whether it's psychotherapeutic intervention, whether it's spirituality, it's like the tripod in so many ways that can help uplift possible patient. I want to ask you, what would you say to a family that's resisting getting psychiatric medicines for their kid who might be struggling with severe depression, who might be struggling with a mood disorder, some mental illness for which there are medicines out there that can bring significant improvement in their quality of life?
So I think the approach that I've found works is first acknowledging that resistance. Give it its space to breathe in that conversation. Because oftentimes behind resistance is either lack of education or fear. Either their own lived experience has been bad, or they know someone who had a bad side effect with medication, or there's that fear of log kya kahenge, wo to pagal khane chala gaya, and stuff like that, right? So acknowledging that resistance and then creating a space for dialogue and educating them about the biology of mental illness. Do we shame anyone into not getting their asthma better just by willpower? Now, it doesn't mean the person doesn't have any agency in controlling it, right? The problem, the challenge in mental health and psychiatry is that it's fuzzy. You don't have clear markers. Where I go to my doctor and he says 120 is the upper normal of blood pressure. I can see it's 135. That makes sense. I've got an objective point to anchor myself in. So I use the word a lot, functional impairment. in my discussion with patients and families that, okay, let's forget about diagnosis. Let's forget about labeling. Can we all agree that this person is impacted in their life by their moods not being regulated, that impacts their work, their relationship, their own sense of self, or their anxiety, or their thought process, right? Okay, once we've agreed upon that, let me educate you about the biology of how our brain regulates these things. And then let me educate you about medicine is just one aspect. Medicine is an important aspect. It gets you to a point where you can actually engage in therapy more effectively. I think our mental health system also is to blame. I'll be very candid, where we have disconnected. Our healthcare system is fragmented, where we've put physicians as glorified pill pushers. So now you've got these 7.5 minute med checks. I don't even know my patient's last name. And let's just play Russian roulette. Is it Zoloft today, Prozac tomorrow? And patients say this isn't working. But then they're going to therapy, and biologically their system is not in homeostasis. So therapy is not working. And then our therapists and our doctors aren't talking to each other because we're busy. And the patients are getting more and more and more disillusioned by this, right? The more we can educate, it's not either or. It's you cannot perform effectively in one aspect of your psychology. If the hardware is not working, the software won't work effectively.
Absolutely. Thank you so much. That was really well explained. I'm going to tap into one more expertise of yours, and that's addiction. There's a lot of shame around people who unfortunately experience that, especially in our community, where they would rather not acknowledge that someone is an alcoholic or is struggling with drug addiction, gaming addiction, porn addiction. Talk to me a little bit and educate our listeners on how not to be unkind, because a lot of times the whole idea is, well, they're choosing this. There's no empathy. There's no compassion. You know, when somebody has a surgery or somebody has an illness, there's a lot of community support. When their family is affected by someone who is struggling with an addiction, they're isolated.
Just for the listeners to hear again something extremely important that you mentioned. Addiction is not about drugs also. It is process addiction, porn addiction, love addiction, people pleasing, work addiction, exercise addiction, food addiction, right? We oftentimes don't recognize that those things actually have the same biological substrate than someone who's struggling with alcohol or cocaine or cannabis, right? And the challenge is that if we don't understand addiction as a brain illness, then we project onto the person who's found themselves in the cycle of addiction as if it's a moral failure. Because what does a person out of shame and guilt do when they're unable to change their behavior despite poor outcomes? They're going to lie. They're going to promise the 100th time. They're going to hustle. They're going to cheat. And so the loved ones have a deficit of trust. But in that deficit of trust then is projected this morality. What's wrong with you, right? So then self-sabotaging behavior comes in, because when the biological imperative to continue a habit loop continues, then we start developing these stinking thinking scripts. Well, you know what? Maybe what they're saying is true. Maybe I am broken. Maybe I am damaged. So if that's the case, then what the frick, might as well keep doing what I'm doing because nobody, right? And so we end up, how we engage with the people we're trying to help, we actually push them deeper into the addiction. So there's a lot of need for educating about the biological model. I have the opportunity to work with high net worth individuals who tell me across the table, Dr. Latif, I have been successful in all these aspects of my life, but this is just one area where I can't seem to. And that's where we sit down and explain the brain illness, because all of your motivation and all of your desire and grit is a frontal lobe phenomenon, our executive function of the brain. Addiction lies in our preverbal brain, and no matter how intelligent we are, by definition, our midbrain, we cannot access it with language. The decisions of our midbrain limbic system are seen externally in our behavior. So an old analytic term was repetition compulsion. Why does someone keep doing something that outwardly is harmful to them, and yet they're unable to stop? And if you amplify that, that is what happens in those micro scrolling, micro bursts of dopamine. People confuse dopamine as the pleasure and reward chemical. It's actually a chemical that engages in curiosity, right? And the intermittent reward of addiction behavior actually settles addiction loops much more. Otherwise, we extinguish, those behaviors. But you have to really be well trained and nuanced nuanced in that discussion, because if you approach it, well, it's all your biology, then the patient who's struggling with addiction says, yep, sure, dude,
Home
it's my
free. Yep.
I'm home free. I have no agency or responsibility. So getting in front of the rightly trained people is important. And majority of addiction is a dual diagnosis. Addiction doesn't happen in a bubble. There's a whole other psychodrama and psychological context that are feeding this. And that's why we have the saying of a dry drunk. You might be sober, but the patterns that got you into the behavior, you're still showing them up in your marriage.
Absolutely. The systemic component shows up so strongly. You're absolutely right. I see it all the time. I see that with divorces becoming a very higher number in our community. And you mentioned love addiction. So many times my clients have heard that term for the first time when I'm telling them about it. That, when you are getting fed those dopamine micro hits of the love bombing, it's very hard for you then to walk away from the abusive behavior.
So one of the things that in our training, we used to talk about the fight or flight. Then we added another understanding of fight, flight, or freeze. Now, fight, flight, freeze, or fawning. Our culture rewards fawning behavior, right? So we, ironically, collectively, are well trained in how to stay stuck in trauma loops because we're well trained in those defense mechanisms of that, right? And so it's complicated, but at the same time, it's very simple when you start knowing where to look at it.
So many times I'll hear like, "Ye jaan booj ke kara,"
Yep.
and when I try to simplify, I'm like, they're actually trying to solve a problem. I want to bring your attention to something that's being talked about a lot, and I really feel that, especially when I have quite a larger percentage of a gender that's very underrepresented in the mental health space. I work a lot with men. There's a lot of stereotyping, almost to the extent where the good men, toxic masculinity, and men are abusers and all of that. And a lot of the good men and the good behavior and the ones that are showing up beautifully, they're very, very underrepresented. And a lot of men feel like they don't have the space in our community to be vulnerable because of the very heavy expectations from them. They're not just providers of sustenance or quality of life for their families. There is especially given the immigrant diaspora, there are parents now, there are people back home, they have a lot of fear, and that kind of perpetuates that whole performative thing. Talk to me about what trends you're seeing with South Asian men. Do you see improvement? Do you see that the space is a little bit safer for them to access in terms of mental health services?
There's hope. There is hope and there is improvement. I mean, just the very fact that a core demographic of your patients are these very high functioning men, you're creating a space for them to be vulnerable and just let that uniform of that outward identity, just put it aside and let's have a real talk, right? Just that space is incredibly healing. We talk about physicians. Physicians have imposter syndrome till the day they retire. And having imposter syndrome by itself is not bad. But the world thinks doctors cannot make mistakes. Doctors should know everything. This chat GPT that I did today and printed out for my doctor, what do you mean he doesn't know about this new gene, right? So the imposter syndrome is real. It's when it becomes a source of corruption into other areas of identity. That's when implosion happens, right? We are seeing a really good social education of men leading the discussion of reducing stigma. We see it in our veteran space. There was this ad, Real Men Cry, and you're showing this soldier who is this pillar of strength, but he's being genuine and authentic. The other thing is, with this particular cohort, not the traditional midlife crisis that we talk about, but we start seeing this kind of peak of their career 40, 50, maybe 55, and they're lonely. They're just lonely. And we know biologically, for example, in my geriatric cohort, there's studies that have been replicated. Loneliness accelerates medical illnesses as much as smoking a pack of cigarettes a day, if not more. Your chances of dying by heart attack are more, your diseases are more, you have early morbidity, mortality, and stuff. So genuine spaces to connect with your own core identity without being defined as connected to someone else. I'm the breadwinner, I'm the spouse, I'm the parent, I'm the boss, I'm the employer, I'm the employee and stuff, right? There is a movement now gradually where I'm seeing hope, but it's too little. Where I see the opportunity gap is if you have a rushed clinician, then that person who's coming prepared to be vulnerable, that can be a very scary space. It's like doctors and therapists have with training pattern recognition within the first 10 minutes a good idea where the lay of the land is. Our patients are assessing us too. It is a incredible privilege in mental health care as a practitioner to sit across the table for someone who is sharing with you things they've not shared with, let alone their spouses, with their own selves. And that is a fragile place of trust. Not to understand that, we do more disservice then. Why do we think there's this statistic that the increased risk of a completed suicide in the first month after seeking inpatient care is high? Because our healthcare system at times unintentionally furthers the sense of, well, I gave it my best, but if this is what the best is being offered, I don't know what else to do.
There's no hope.
But there's no hope.
Thank you so much. You touched on something that I'd love for you to talk about for a couple of minutes, the geriatric population, and also our immigrants and where they are in that whole cycle of life and the generational challenges and the trauma. Many of us are in that space where we're caring for children. We have aging parents that are showing signs of disease such as dementia, Alzheimer's, and it is creating its own challenges in that space in our realm. Could you share a little bit about what you're noticing?
When I finished fellowship 20 years ago, there was not a lot that we could offer to our patients early on for prevention. Once the disease manifested in dementia, the disease process was already 10 or 15 years in the making. The science has progressed where we really need to look early on at mild cognitive impairment. But mild cognitive impairment is hiding in plain sight. So we need to get our aging population early on for screening and intervention for modifiable versus non-modifiable risk factors, right? You talked about the sandwich generation. The daughters, and this is not unique to our South Asian culture. This is here in the United States. It's actually internationally known. It's the adult daughters who are the sandwich generation taking care of ailing parents and their own families, and they're being squeezed in the middle. And that does real harm to them. There's a process when we've moved in the elder generation from mild cognitive impairment to actual early dementia. There's a role reversal now that the adult children are becoming proxy parents. And that brings out very healthy or unhealthy childhood dynamics that everyone in the family felt we'd have outgrown on, but those instinctual kind of psychodrama starts getting played, where there's this frustration and lack of understanding, but I want to do something and I'm feeling guilty. By golly, I will never put my parent in a nursing home, but I'm exhausted in not being able to be their nurse at home. All of those things are a family intervention, not just putting someone on memory pills. So caregiver burden is very real. Caregiver guilt is very real. And there's something else that is real that I think culturally we need to have more education of is anticipatory grief. Because intellectually we know if someone has a terminal illness and we can't really do any more disease modification. Intellectually, we know that we all live finite lives. And then when we don't sit and acknowledge a very normal human emotion, remember we started the conversation with cognitive dissonance, right? So this is a nice kind of bringing it back. Then you're sitting in with this, I'm not going to acknowledge that as a caregiver, I'm resenting some of the things I have to do. Tell my boss that I'm so sorry I have to take another day off, or spend out of my savings now money for long-term health care. Not acknowledging those resentments and normalizing them gets shoved in and comes out in the form of then poor caregiving. And I haven't, that'll be a whole other probably episode about elder abuse.
Absolutely. And I'm already writing that down because you've said so many important components. And as we were talking about the intergenerational trauma response, the fawning, and why I think it just perpetuates is that our culture really positively reinforces it.
Yeah.
You get like all this positive accolade for not doing self-care.
Yeah.
For not taking care of your own health, your rest, because you are doing khidmat or serving at the cost of your peace of mind at the cost of ignoring your own children who may need a little bit more attention. So it's like this cycle of toxic service that is really building resentment in the family system, which then shows up as elder abuse in so many ways.
And it perpetuates the generational trauma because now the young children who are growing up in absence because this two generations are caught in their own loop right now. So now you're seeing an exit drift again.
I'm going to end with you sharing for our listeners what would be certain things that should warrant them seeking psychiatric help immediately when they look at their child, when they look at themselves.
So the biggest one is safety. And what I tell family members is it is not the burden of a family member to determine is someone safe or not. Are they suicidal or are they just threatening it and stuff because they're not skilled and trained in it? It is a science and an art to understand imminent suicide versus not. Even if you're thinking that safety is an issue, please get them in front of professional help and unburden yourself and then let the professionals do the work. There's no second guessing. The other thing is, if you're seeing a marked shift in behaviors and moods and social interaction that was not there, that is sustained, it's not just 1 or 2 days or something, seek professional help. Don't burden yourself with Googling or ChatGPT, is this bipolar? This is not bipolar. I'm explaining this away. And these are hard biological constructs. And the biggest challenge I see is in like early onset schizophrenia or drug-induced psychosis. Those are very complicated, nuanced clinical presentations you need to get in front of a psychiatrist. So normalize the conversation for your loved one that if you're going to take them to a psychiatrist and a therapist, you're actually their ally just like you would if they had a fever.
This was so helpful. Thank you so much. I know I could go on with questions for you, so I will just have to invite you every few months to talk about a different topic. Also, because I struggle with finding strong advocates of psychiatry who can really simplify and have the kind of compassion you have for patients, for our community, and all the great work you do. Thank you so much for being here on Dil Ki Recipes, and looking forward to seeing you again.
I really enjoyed it. And again, thank you, Sheeza, for the work you're doing because it is in our DFW community and even beyond, because I know you've had clients we've shared that are outside the larger DFW footprint. It's having a real impact. And I think that that impact is going to have a halo effect and a trickle effect in the community. So excellent work.
Thank you. Thank you so much.
Please remember to keep listening and watching as part of your weekly self-care and learning ritual. You know there are lots of commonalities in our lives, relationships, in our joys and struggles. And my hope is that this material will help you expand your perspective, give you some clarity on how to think about things, and ultimately make you feel better and sorted about your life and relationships. Hope you have a fulfilling and wholesome day.